Good afternoon, everyone, and welcome to another session of the 2020 Suicide Prevention Summit. And for this session, who is joining me is Joe Calleja. Joe, thank you so much for joining us. It's your second participation in this event. How are you feeling today?
Very well, thank you, Pedro. Yeah, nice sunny day here in Perth.
Wonderful to hear, wonderful to hear. So this session is about emerging solutions for suicide prevention, and you suggest pathways to change ineffective strategies to prevent suicide in Australia. So it's going to be a very interesting session. Last year when you spoke to us, you talked about peer work, so that was a great talk too. But before we move on to the presentation, let me give our participants a brief background on you so they know who you are. So Joe is a social worker, life member of the Australian College of Social Work and graduate of the Australian Institute of Company Directors. In the past 2 years, he has been a member of the National Suicide Prevention Project Reference Group for the implementation of the 5th National Mental Health and Suicide Prevention Plan and on the reference group for the WA Suicide Prevention Plan. Joe, I picked up the last couple of projects you were involved in. There are a few more over the last few years that you were involved in. Is there anything that you'd like to just pop out so people know that you were a part of it, or do you want to just introduce that during the presentation?
I'll just mention that I was involved in setting up the recovery colleges here in WA, and that no doubt across Australia they're going to be something to look forward to in the future.
Wonderful, wonderful. So before we get started on Joe's presentation, I'm going to quickly repeat our webinar rules, especially relevant if this is your first webinar with us. So first thing you notice is that you cannot talk during the webinar, but you can submit questions in writing via the questions tab of your GoToWebinar control panel. You can submit questions at any point in the presentation, but at the end, we're going to do a Q&A and we're going to try to cover as many presentations as possible. As questions as possible. Second thing is this session is being recorded and the recording will be available tonight along with a link to download the slides. So keep an eye on your email. Around 8 p.m. you get an email with that information. If you don't, shoot an email to help@mentalhealthacademy.com.au and we'll check it out for you. Now, Joe, that's it for me. I will be back in approximately 45 minutes, but in the meantime, I hope everybody enjoys the presentation and I look forward to our Q&A.
Thank you, Pedro, and good afternoon, everyone. I would like to acknowledge that we are conducting this online summit on the lands of the First Nations people of Australia, and pay my respects to the elders and leaders past and present and emerging. I'd also like to thank the Mental Health Academy for holding this online suicide prevention summit. We also remember those we have lost to suicide and acknowledge the suffering suicide brings when it touches our lives. I'm a social worker by profession, and for 11 years, from 2005 to 2016, was the CEO of Richmond Wellbeing of Western Australia, which is a non-government mental health organisation. And prior to this, I worked in the fields of child protection, family relationships, justice, disability, and the community sector. My current interest in suicide prevention arises from the experience in these areas. None of the sectors saw suicide prevention as an area they felt they had expertise to provide support. In all of these areas, the tendency would have been to refer to specialist services, someone else's responsibility. Now I can see clearly that all of these and other sectors have an equal role to play in working with suicidal distress, but this is not happening today. What I will focus on today are the solutions I see emerging in reducing levels of suicide. This aligns with the new direction taken by the Commonwealth that suicide prevention is a whole of government responsibility. Suicide prevention is also a whole of community responsibility. However, the transition to this awareness in both sectors requires considerable work. I'm having trouble with my slides here.
Joe, try using your keyboard and see if that changes to the next one.
There we go. That's it. Thank you.
Great.
The objectives of this talk are to identify to outline the gap, why we need the voice of lived experience, other changes possible, including what we might learn from COVID-19 response, and emerging innovations which can help address the rate of suicide. I want to briefly explain the terminology I will use in this presentation so we have a shared understanding. Lived experience refers to one's own experience in contact with suicide as outlined by Roses in the Ocean. People with a lived experience find support in connecting with each other. There we go. Self-help groups are comprised of people who share the same experience and are able to provide help and support to each other. WA is fortunate to have connect groups as the peak for hundreds of support groups in Western Australia. And self-help groups are well established worldwide as being a valuable resource for people to have a life in the community. And I'll refer to peer support in this presentation as the self-help in suicide prevention. So looking at the first objective, the gap and why we need the voice of lived experience. And the gap in our system is the unfettered voice of lived experience of suicide. Our current system does not allow the voice of lived experience of suicide to speak unless it is filtered through the lens of professionals or organisations. Those of you who have seen the 3-minute video of Will Hall from the US talking about suicide would have heard a description of the system's response to suicide. He describes the system as one where we have reached a point where we see the feelings of suicide as being the product of a biological brain disorder. A response which generates fear that people do not necessarily want to give up on life. Suicide feelings are a desperate need to change one's life and a desperate feeling of powerlessness. And we have to talk to people to understand. His description of that system is a mirror image of Australia. We need to reframe our approach to shift our system to one which allows people to safely talk about their distress without being judged, to a system which is based on social justice and human rights, and which responds to distress as a human experience, not as a biological brain disorder that needs to be medicated. Developing a rights framework in response to various human conditions has occurred in Australia, in the disability and aged care sectors in particular, with a shift from treatment focus to a rights based on individual rights and needs. Indigo Daya, a mental health consumer leader who also experienced suicidal distress, including attempts, talks about the double bind she faced. If I don't do something, I will die. If I do something, I might be tipped over the edge. She spoke about intervention from a social justice and human rights perspective. There is no safety in suicide prevention if we don't have human rights. We need to recognise emotional and spiritual dimensions in our lives. Understand our behaviours can be reactions to social determinants, to impact of trauma and experience of diversity, to co-design services to meet citizen needs, and to be led by consumer leadership with professionals on tap, not on top. And so services must be based on different foundations. Professionals relinquishing power through co-production, increasing the focus on connectivity through deep listening, promoting hope through peer support, supporting people to have a meaningful life, addressing the social determinants, enabling people to make sense of their experiences, asking what happened to you rather than what's the matter with you, and enabling people to regain a sense of their identity, living a more meaningful life in the community. This will require a major rethink of research, policy and service design. We need to move from the negative rights to positive rights. And for suicide prevention sector, this requires we genuinely engage with the lived experience, recognising both knowledge by experience and knowledge by profession. So we need a system which supports and values relationships between people, rather than seeing the individual as the problem or issue, or as a case or as a diagnosis. There is a growing body of evidence which questions the effectiveness of its medication without the direct engagement of patient feedback. Eminent British psychiatrist Joanna Moncrief and others argue this reorientation would demand that people prescribed medications are treated as informed consumers rather than passive recipients of diagnosis-driven prescribing. The user's subjective experience should guide the use of psychiatric medications in a collaborative dialogue with the prescriber rather than changes in designated symptoms or clusters of symptoms. And there's a link at the bottom of this slide to a guide for consumers to have a discussion with their doctor or psychiatrist about medication. So we need to change the narrative around suicide intervention. Barbara Disley, inaugural Mental Health Commissioner in New Zealand and current Group Chief Executive of Emerge Aotearoa in New Zealand, has said, "You need to change the people around the table if you want to change the discussion." Until recently, the primary people around the table were health professionals, mainly doctors, nurses and psychiatrists, and possibly a smattering of allied health and some community sector representatives. The driving body was the Commonwealth Department for Health. That changed with the Prime Minister's announcement of July 2019, when he appointed a special advisor on suicide prevention to provide him with advice, instead of having that advice only from the Department of Health via the Minister for Health. Suicide prevention would now be considered from a whole of government perspective. This shift of perspective has raised much hope in the sector. Christine Morgan is the Prime Minister's advisor and is also the CEO of the National Mental Health Commission. She has a secretariat of health professionals support her in the advisor role and has presented an interim report for a plan of action in that capacity. Have the people around the table changed in relation to suicide prevention? One could safely say they have been broadened and there is less dominance from a medical perspective. But the treatment response still remains the key driver so far. None of the Prime Minister's announcements have reflected a radical departure from the treatment-based approach currently in place. Some would argue strongly that the advisor and secretariat are also guided by the voice of lived experience through an advisory panel. Therein lies the first test of real change. Lived experience is not directly at the table. For genuine change to occur, the voice of lived experience must be in all parts of this process, not on the edge, providing advice that would be filtered through the lens of others. Last year, the West Australian Minister for Health, Mental Health, commissioned a review of clinical governance of mental health. The Minister appointed a key family and consumer leader to the panel of psychiatrists. This meant that she participated in all of the discussions that were central to decision making. It demonstrated an awareness that clinical governance is fundamentally about safety and quality for consumer outcomes. Rather than being about health professionals alone, had she only been in an advisory role, she would have been dealing with predetermined views rather than influencing the discussion. And I believe that the successful transition of suicide prevention from a medical base to a social base in Australia will not occur without the genuine engagement of lived experience from the outset. Now is the time to bring in the direct voice of lived experience. There are 6 priority areas identified by the Prime Minister's task force. How these are approached will be critical in addressing the gap. Otherwise, we risk simply having more of the same with minor variations. I won't go into detail on these due to time constraints. Instead, I'll make one response to each priority area where I believe an opportunity for reform exists. The whole of government response must recognise the important contribution of the community sector. In their daily lives, people receive significant support in the community, whether it be through organisations or local networks other than from government. Much is said about adopting a no wrong door approach, but we need to ensure the doors are genuinely open. This involves genuine partnerships between government and the community sector and a willingness to tailor services to meet citizens' needs. To achieve that tailoring, citizens need their voice to be heard. Early distress responses using community and government touchpoints are critical. The task force is silent on the role of non-clinical peer support, even though it acknowledges the importance of lived experience. What has been proposed is the extension of national trials, which are treatment defined, and community touchpoints, which are still defined by professional interventions, neither of which have a uniform evaluation strategy. A critical gap in our suicide prevention system is non-clinical peer support without clinician involvement. In the current continuum of responses to suicide, non-clinical peer support should be the starting point in our system, as it allows choice around clinical engagement. Responding to the specific needs of communities and groups at very high risk is important and offers further opportunity to trial non-clinical peer support. Allowing these groups a direct voice in how their needs should be met is critical, rather than only having these needs defined by professionals, researchers, and others. The enhanced health response to suicidal distress is a critical area as well. And one of the key mechanisms of engaging in the community is through the primary health networks and their role in primary care. Yet the Commonwealth Department of Health insists that any activity undertaken by a PHN must be treatment-based. This will continue imposing serious constraints on how PHNs can respond. Peer support without clinical intervention can never be funded with those constraints. PHN funding needs some restrictions lifted. Support for family and friends along the continuum of suicidal behaviour is fundamental. The task force also recommends growth of the peer workforce. However, we need to distinguish between the role of peer support groups and the role of peer workers. The task force is silent on peer-to-peer support and only focuses on the role of peer work. Peer-to-peer support in suicide prevention is different from peer work. It is peer support within a self-directed context where skilled, trained facilitators are present as peers, and this is a critical gap. Collection of good data is fundamental. New approaches to data collection need to be co-designed with people who have experienced suicidal distress and the family and friendship networks. All too often, researchers will suggest material has been co-designed simply because they have consulted on a document. We need to shift from a traditional evidence-based approach, which excludes the voice of lived experience, to evidence-informed, which includes their voice. The National Mental Health Commission has been tasked to develop a specific suicide intervention research strategy, so there is a possibility this shift will happen. The task force report includes references to the Productivity Commission October 2019 draft report on its inquiry into mental health services. Any reliance on those recommendations need to be taken with considerable care, as the Productivity Commission draft report is based on an assumption that medical treatment and intervention is the first step in responding to mental health problems and suicidal distress. This is fundamentally the wrong approach, especially as the Productivity Commission describes psychosocial support as only being provided when treatment fails. Psychosocial support is what people need and experience in their day-to-day lives. Treatment is just one component of their life. There are some sound recommendations made by the Productivity Commission, but they are undermined by the basis on which their draft report is built, and it would be a serious mistake for the Prime Minister's task force to mirror this in its work on suicide prevention. The second objective is to look at other changes that are possible, including what we might learn from the COVID-19 response. If we look at return on investment, the task force report suggests that we talk about investment rather than expenditure in suicide intervention. Investment would be guided by outcomes required. We know current expenditure runs into the hundreds of millions of dollars, although no one can say exactly how much is spent. It is increasing every year, yet suicide rates continue to increase. A private business spending this money with no actual return on investment would argue something needs to change. Identifying the changes will be the challenge for the Prime Minister's advisor, because it will mean asking some difficult questions and challenging some entrenched beliefs and approaches. Well, what are the changes that agencies can make that could help improve response to suicidal distress? Suicide intervention services in Australia are still generally defined from a treatment perspective. However, even within this framework, it is still possible to respond to suicidal distress from a person-centred perspective, placing lived experience in the centre rather than on the side. Changes in approach to governance, leadership, language, workforce, auspicing and training can make a significant difference even within the current treatment defined system. And the changes I'm proposing below are within the scope to achieve now and aren't reliant on further inquiries or reviews. In governance, some comparison with the mental health sector is useful. Many agencies and state peaks have positions on boards identified for individuals with the lived experience, and they allocate full voting rights to members with a lived experience. This is not the case in the suicide prevention sector. Suicide Prevention Australia, the peak body for the member organisations, allows people with a lived experience to become an associate member and to nominate for a board, but they are not allowed to vote, even for themselves. It is hard for SPA to argue strong leadership under these circumstances. The sector only exists because there are people in suicidal distress. Therefore, SPA agencies only receive funding for that reason. The inclusion of people with a lived experience as individuals needs to be a central part of agencies' approach to governance. Otherwise, they continue to support a system which controls rather than encourages lived experience leadership. Why would member agencies of SPA change if Suicide Prevention Australia itself, as the peak body, retains a paternalistic approach? And continuing the theme of lived experience leadership, the mental health sector is growing consumer and family leadership with new national structures emerging in recent years. This is not the case in the suicide prevention sector. Although there are leaders emerging, they tend to be recognised only through an organisational context rather than through external consumer and carer networks. Strengthening the individual voice of lived experience leadership is achievable, and Suicide Prevention Australia and all agencies have a role to play, and now is the best time to grow this leadership. In relation to language, Suicide Prevention Australia has an excellent language guide. We need to go further though, because other language commonly used in the sector is still treatment directed, and we should be normalising it as much as possible. For example, the suicidal ideation is a term we should discontinue, as it is a treatment-oriented term, suggesting illness rather than distress. How we refer to people is important. Describing someone as a case or by a diagnosis needs to be discontinued. It can be done. The disability sector has managed language for many years. In relation to workforce, much has been said about the need to develop workforce in suicide prevention sector. This includes developing both the mainstream workforce as well as peer workers. The tone of workforce discussions is usually about the future. However, much can be done now in relation to peer support and education within the existing workforce. Employers can include lived experience as one of the criteria for positions advertised, which are not peer specific but part of their general workforce. Employers can also classify peer workers at levels which form part of the general workforce classification, instead of automatically assuming they should be the lowest paid staff. Putting peer workers on the bottom rung is yet another form of discrimination and stigma. If a person has other qualifications which would normally be recognised in the agency, the peer position should be paid accordingly. And employers also need to employ peer workers in pairs. Peer work is challenging and has its own support needs, so the isolation is unhelpful. In relation to auspicing, agencies can help grow innovation without being funded to do so by supporting grassroots initiatives such as peer-to-peer support groups. Where agencies actually have paid staff who run the groups, they need to allow the groups to be run in the way they are intended, rather than as a program of the agency. And organisations may find it easier to auspice peer support groups. They can do this by paying the facilitators as contractors to run the groups and to support the groups in other ways by providing insurance cover, consumables such as coffee and tea and biscuits. Auspicing will help grow peer-to-peer groups and other innovations. In relation to training, I want to spend a bit more time on the issue of staff training because it's fairly central to agency culture and service delivery. The training I have seen in the suicide prevention sector has been clinician or professional led. It is tended towards diagnostic approaches. Assist and STARS training are more person-centred and highly regarded. Even so, I believe the current suite of training offered contributes to a sense of stuckness in the current approach to suicide intervention. There are some whole of organisation approaches which are more person-centred coming into Australia. Zero suicide from the US with a heavy peer emphasis driven by David Covington and has had considerable exposure on the eastern seaboard with some interest in Western Australia also. There has been a recent announcement of employing a large number of peer workers in New South Wales to further promote this approach. And there's also the Form Mental Health compassion-based approach from the UK, driven by Alice Cole King, and the approach has had extensive exposure in South Australia and Tasmania. This is strongly person-centred and seeks to understand the basis of distress. So those two approaches move from the diagnostic to a person-centred approach, but they still have their limitations in relation to engaging the voice of individual lived experience. So I want to describe two approaches which challenge current thinking about training in suicide intervention and are slowly being introduced in Australia. These are the alternatives to suicide training and the emotional CPR training. Alternatives to suicide, the foundation of this training is the alternatives to suicide approach, which gives voice to the lived experience of suicide. This is a peer-to-peer support group comprised of people who have attempted to take their lives or who have thoughts about suicide. No clinicians are involved, and groups are facilitated by two trained facilitators with the lived experience of suicide. The group provides an opportunity for individuals to share with others in a way which is safe and does not involve risk assessment or intervention or pathologises them, instead having others simply listening to their distress and walking alongside them. The strength of this approach lies in the peer nature of the support. The training that is based on this approach will provide an important contribution in Australia. The training is not about risk assessment or diagnosis. It is about how to understand a person's experience, which has led them to this dark place. The facilitators are people who have been in that space themselves. They have been trained in group facilitation, so they understand both the individual experience, but are also skilled in working with groups. They explain how to explore feelings through curious questioning and deep listening. They also spend some time working through the myths of suicide and explaining the ACEs research, which clearly identifies the role of trauma in our lives. The steering committee in WA, of which I am a member, is well advanced in plans to bring the US trainers back to Australia to run a 5-day facilitated train-the-trainer, a 3-day facilitated training, plus conversations in suicide training, which is a 2-day program. These will add to the choice within the suicide prevention sector in Australia. Training will be delivered by people with the lived experience of suicide instead of a clinician or a trainer. This approach was considered to be culturally safe for Aboriginal people when a group of elders and leaders met with the trainers from the US in Perth in February 2017. I'll talk more about an actual alternative to suicide peer-to-peer group that has been running in Perth for 2 years later in this presentation. One of the criticisms made of professionals is they don't hear the distress. Unfortunately, most of our suicide and mental health training programs compound this behaviour. The risk assessment tool comes out and the professional looks at the checklist and stops listening. Emotional CPR training was developed by Dr. Daniel Fisher, a US psychiatrist with a lived experience. He developed eCPR in response to his concerns about what he felt was a diagnostic approach of the mental health first aid approach and its popularity amongst professionals. Unlike much of the training professionals are exposed to, it is not based on risk assessment or diagnosis. It is based on the belief that we are the tool. It is based on bringing your humanity to the process, and the six intentions involved are to listen with the eyes and ears and heart, to share feelings but be present, to be agenda free, to support a person in uncovering what's right for them, together accessing the power to heal, and creating a life together which is revitalising. Emotional CPR has a growing presence in Australia. Training has been facilitated by Inside Out Conversations in Sydney and the Humane Clinic in Adelaide. It's time for the suicide prevention sector to break out of its current repetitive cycle of suicide prevention training and allow some new approaches to be included in the suite that are offered. Approaches based on deep listening to instill hope in people's lives. Professionals need the opportunity to learn from lived experience, and I would encourage agencies to consider including a wider range of options. We are in the middle of a pandemic with COVID-19, so while we are considering how agencies might be able to change in the way they respond to suicide intervention, it makes sense to see how COVID-19 decisions might offer a learning opportunity for change in the suicide intervention sector. Clearly, the COVID-19 and suicide prevention are different issues requiring different strategies. However, we know from COVID-19 it is possible to make changes faster than previously thought. The urgency of COVID-19 has broken through the previously slow-moving progress on telehealth, enabled the inclusion of new Medicare items, included temporary payments, and other economic measures not previously considered part of a traditional coalition response. The critical danger posed by the virus to our community acted as a catalyst for significant change. In the suicide prevention sector, innovative approaches to research, peer support, and funding have been blocked or slowed down by tradition, stigma, vested interest, and professional barriers. Now is the time to reduce or remove these if we are to maximise opportunity for change in this shift to whole of government response. So I want to turn now to some emerging innovations which can also help address the rate of suicide. We need to remember that change is possible because the human mind doesn't stand still, but human action can stifle or prevent change. If we reflect back on some of the major shifts in our approach to social issues, we can see how earlier thinking by professionals was misplaced or misguided. For example, there was a time when being gay was considered to be a mental illness. There was a time when no one believed that sexual abuse occurred within the family. There was a time when domestic violence was dismissed by police as being a domestic and it was no one else's business. There was a time when no one was encouraged to report sexual assaults because of the blame the victim attitude and convictions were rare. There was a time when gender identity was only considered as being a man or a woman. There was a time when people with mental health problems would never have been considered to have had an opinion worth listening to. And there was a time when no one even talked openly in public about the issue of suicide, but now it is recognised as a major social issue. And there was a time when people were not encouraged to talk about their thoughts of suicide, but now it is encouraged. This is the time for change in the way we respond to people who are in suicidal distress, people who might see suicide as the solution, not the problem. We can support them in finding other solutions. The challenge in our system is to trust people with a lived experience of suicide attempt or distress to be directly involved in advising and informing professionals and services on what works best for them in dealing with their distress, not just through family and friends, but through direct conversation. There are some emerging innovations that will help change the landscape of suicide intervention if they are adopted or promoted or grown in Australia. The power threat meaning approach to working with individuals creates a genuine person-centred engagement which doesn't judge but helps the professional more clearly understand the basis of distress. It was funded by the British Psychological Society. It is co-designed with lived experience and focuses on the importance of acknowledging the reality of people's experience of distress. We know how imposing a diagnosis often can be very damaging to people by turning people with problems into patients with illnesses. It is why we need to move towards the survivor slogan. Instead of asking what is wrong with you, ask what happened to you. The approach is based around the four main questions, which are what has happened to you, how did it affect you, what sense did you make of it, what did you have to do to survive, and then of course, what is your story? It offers a different way for professionals to understand what is happening in someone's life. This is becoming more well known in Australia, and information sessions on the approach have been sponsored by the Blue Knot Foundation in Sydney and the Humane Clinic in Adelaide. I mentioned the alternatives to suicide groups earlier when I was contextualising the training around this approach. The alternatives to suicide approach was developed because the opportunity to talk openly about suicide and feelings of deep emotional distress with others who have or are experiencing similar struggles can be a powerful way to support people to move through those darkest places. However, people were being denied that opportunity in traditional response settings. These groups provided a setting in which those discussions could take place without fear. And they were developed by the Western Massachusetts Recovery Learning Community in the US. During groups, people share their successes and their challenges, provide support for one another, and strategize and share ideas for coping with difficult life circumstances. Individuals need not identify as being in crisis in order to attend. People are supported by staying in the dialogue, asking why do they want to end their life? Why don't they want to end their life? The groups are life promoting and empowering because the hope for a different way of living was already there in the room. These groups have been running in the US state of Massachusetts since 2008, 12 years now. They continue to be funded through a combination of philanthropic funding and funding from the Massachusetts Mental Health Authority. All I need is someone to talk to is the title of a small ethics-approved evaluation of a Perth-based trans-folk suicide peer support group that has been running for 2 years without clinician involvement. It is based on the Alternatives to Suicide approach, and the facilitators have been mentored through it through video and phone conversations with the facilitators from the US, as well as supported locally by Connect groups in Western Australia. The myth that peers learn techniques from each other of how to end their lives is just that, a myth. The attendees at the Discharge Peer Support Group in Perth found safety, comfort, hope and trust in a non-judgmental environment. The evaluation project with Curtin University highlighted a series of key impacts that group attendance is having. Group participants have become empowered to navigate their thoughts of suicide, prolonging the time between thoughts of suicide and a suicide attempt, if there is any attempt at all. Participants appear to be gaining a greater sense of control, meaning they are less likely to act on suicidal urges without thinking about the feelings and what they represent. Participants find different ways to explore and debrief around triggers. Discharged, which is the name of the group, the group running these sessions, is creating the conditions for participants to move through triggers, leading to healing rather than further traumatization. Knowing that discharged meetings are a regular, safe place means participants can respond to challenging emotions by reflecting, delaying, and holding on until the next scheduled meeting, rather than making a suicide attempt. Participants become empowered to have conversations about suicide in ways they had previously been unable. So groups are running in Perth, run by Discharge, and in Sydney by a separate group of people, both without funding. Will an Australian state or Commonwealth funding body adopt the same vision as the Massachusetts Mental Health Authority in the US and fund peer-to-peer support? I hope so, because for some people, this is the only support they feel they can trust. I want to now look at a range of other innovations. Brook Red is a Brisbane-based peer support agency funded by the Queensland Government. It is peer-run from board through to service delivery, and one of its programs is a peer support service to people with suicidal distress diverted from emergency departments. Although in its early stages, it has the potential to contribute to the growth of peer-to-peer support and diversion in a non-clinical context. Spark Suicide Prevention and Recovery Centre is an independent community living Australia in Sydney, has been funded to trial a new service providing support and care for people experiencing a suicide-related crisis. This includes diversion from emergency departments, and it will be offered in a home-like environment. Due to the COVID-19 crisis, the service could not be opened at the time planned, so the funds have been temporarily diverted to eFriend. eFriend, which is also based in Sydney and run by the independent Community Living Australia, is a new service which has been developed from the redirected Spark funds. It is a peer support telephone or FaceTime line, which is by appointment for up to 6 sessions. Run by peers, it is based on a befriender model from the UK. Although there is clinical support in the background, it is primarily a peer-to-peer support. Then we have safe places or safe havens. A number of states are also introducing diversion programs from emergency departments under the Safe Place program description. These offer a respite for a few hours for a person experiencing suicidal distress. Can be in a home-like environment or in some services in another part of the emergency department. They are peer staffed with clinical support. pardon me, just listening community. This service will be opened in September this year by the Humane Clinic in Adelaide. It will provide a community space to facilitate immediate responses for people in emotional distress, and it functions as a real alternative to medicalised focused approaches within public and other services currently funded. The Humane Clinic is doing remarkable work. They ran the Reawaken Australia program last year for a week in April in Adelaide, and I'd encourage you all to go to the Humane Clinic website to find out more about that and its service about to open. So in relation to postvention, Prevail, Peers for Valued Living, the research is being conducted in the US by Dr. Paul Pfeiffer, a US psychiatrist who previously specialised in veteran suicide research. The period after an inpatient psychiatric hospitalisation is one of especially high risk for death by suicide. The research poses the argument peer support specialists may play an important role by improving hope and connectedness. Initial findings demonstrate that a peer support specialist suicide prevention intervention is feasible and acceptable for patients at high risk for suicide. The Prevail approach is peer-based with clinicians in the background. The Way Back follow-up. The Way Back support service is delivered to people who have been admitted to hospital following a suicide attempt or people experiencing a suicide crisis. Partnering hospitals assess and refer people to the Way Back support coordinators who then contact the person within 24 hours and work with them to develop a safety plan. Although not peer support based, it recognises the need for postvention support where previously a person would have been discharged with no follow-up. It's also encouraging to know there is peer-driven research in Australia around this issue. Suicide Prevention Australia has funded Kerry Jackson in Queensland in her PhD, which is funded from the SPA Research Fund and will make a significant contribution in this area. Whilst continuing on the theme of research, it is not clear how much money is spent on research in suicide prevention in Australia. What is evident, though, is the investment is not reducing rates of suicide. Yet there are new developments in research internationally which provide some hope. Two publications released this month offer new pathways to respond to suicide based on the life-promoting perspectives rather than pathologising suicidal distress. A publication called Alternatives to Suicide, published by the Academic Press, has a collection of chapters, one of which is written by Pat Dudgeon from Australia on Aboriginal and Torres Strait Islander issues. The second publication is The Broader View of Suicide, published by Cambridge Press. There clearly is a growing collection of research that the Australian government can draw from instead of funding more of the same or the same with minor tweaks. Something needs to change. This presentation has outlined the three key areas of consideration for achieving a shift in suicide intervention in Australia. First, I have identified what I believe is a crucial gap in the current system: the lack of an independent voice for the lived experience of suicide, a voice which is not regulated through the intervention of clinicians and researchers, but which is free to speak with others who are experiencing the same distress, a voice from which we can learn new ways of responding. The ability to speak and be heard is fundamental to living a fulfilling life in the community. Suicide is a social justice and human rights issue, not a medical issue which pathologizes distress. The second issue I have covered is how change can be achieved at all levels in the system in order to more effectively work with suicidal distress. Agencies and professionals can choose different approaches to governance, service delivery, training and funding of services. The changes proposed will challenge some of the entrenched thinking and vested interests. This is the key challenge facing the Prime Minister's task force. We have learnt from COVID-19 change can occur. The third issue I covered outlines emerging innovations in the suicide intervention sector. They range from strong peer support responses with clinicians in the background to peer support responses without any clinician engagement. Both approaches are valid. However, peer support without clinician engagement must become an accepted part of the suicide intervention system if genuine change is to be achieved, because it is currently excluded. I also drew attention to new evidence-informed research in 2 publications released this month, which is life-promoting rather than pathologising in its approach to suicide. This research offers the Prime Minister's task force cutting-edge information to consider. I am hopeful for the future of suicide intervention in Australia. I think it is likely we will see a strengthening in the voice of peers, both with a non-clinical setting, such as in peer support groups, and in service delivery, design and research. This would include the broader lived experience of family and carers as well. However, the individuals who have made attempts or thoughts about suicide need to be the focus of change in the first instance. Only they can speak for themselves, rather than always having others speaking on their behalf. The Prime Minister's task force has major work ahead, and its initial report has provided a strong workable draft framework. The challenge lies in ensuring all of the voices are heard in the process of change, including previously silent or muted voices being heard. Thank you.
Thank you very much, Joe. That was great. And for everyone that's out there, the slides are going to be coming to you tonight, so don't worry, because there was a lot of good information there. And I know you want to get your hands on it, especially the slides. In the end, all the links for videos and other resources. Joe, I've got a gazillion questions here, so I'm going to start asking them one after the other. It's going to start from questions that were submitted right at the start, so we might repeat some of the topics a little bit, but just give your best. So the first one is Marissa, and she's asking, how can this information be applied to young people in schools? How much a role can teens play in being support for other teens struggling with thoughts of suicide?
I think that the agencies that are currently working with schools around suicide prevention would benefit from looking at some of the approaches like emotional CPR, which is about engaged listening. The current training for people working in schools is the fairly traditional training that's offered everywhere. And I think one of the challenges of adolescence is young people feel they're not heard, and they feel anxious about revealing or disclosing. So the connection with the distress is really important. I'm sure there are some very good workers out there working in schools, but I think that the kind of training that can be offered through emotional CPR and similar types of approach might actually engage young people a lot more effectively.
Thank you, Joe. Gary's asking for you to comment on why Australia is lagging behind other countries in reducing number of completed suicides. And this was a graph that was shown in today's first presentation.
Look, and this is only my opinion, but the reason I think that is occurring is because we have such a medicalised treatment-based approach rather than an approach that enables people who are in distress to seek help without being judged, without being medicated, without being fearful of what's going to happen to them. It's not uncommon for people to say that the experience of having reached out for help under many circumstances was actually worse than the distress that led to a person wanting to take their life in the first place. So I don't think our system is predicated on the right thinking. I think it is too medicalised and too treatment oriented, and so it's not engaging with the people who are in distress, and it's also not actually targeting a number of populations in a way that they feel they need to be targeted or listened to. So that's the shift in the system we're talking about, the shift from a medical to a social model. I think that will make a difference, provided, of course, that the foundation stone actually starts with talking to people who have those experiences.
Thank you, Joe. Ling is asking, when you say options other than treatment-based by primary healthcare networks, what do you have in mind? Is it feasible to consider a distress management care plan instead of a mental health care plan that is treatment-based?
Well, you see, when something's treatment-based, like if you take PHNs, for example, I've talked today about the discharge group, the alternative to suicide peer-to-peer support group. That can't be funded by a PHN because it's not considered to be treatment. That is, it doesn't have a professional, a psychologist or a social worker or a psychiatrist or whatever connected. So what I'm suggesting is that PHNs and other funding bodies be given the freedom to work with groups and seek from them an understanding of approaches that they're finding are working for people. So, maybe we need to redefine what treatment means, but certainly currently treatment means you need to have someone who is a psychologist or social worker or a psychiatrist or whatever, who will use a risk assessment guide and who may unintentionally or intentionally pathologise somebody when what they need is connection and understanding and listening and support. And PHNs, I don't believe, are in the space to be able to do that under the current funding arrangements. And I actually don't think they understand really that level of connection because it's not part of their brief or their remit.
Thanks, Joe. Stephen saying an Aboriginal worker from Luma stated that we don't people just don't come up here and tick a box and leave again. They want people to stay and help. Is WA looking at placing mental health professionals permanently at remote Aboriginal communities where suicidal rates are the highest in Australia?
Look, I think the people best placed to comment on that are people like Pat Dudgeon and Vanessa Lee, who I believe is going to be giving one of the talks this weekend, is very heavily involved in Aboriginal and Torres Strait Islander suicide prevention and research. So I'd be hesitant to offer an opinion on that. There are people who are actually right in the midst of all of that study and understanding in the Kimberley and other remote communities who are trying to find a solution.
We'll hear from both Leilani and Vanessa on those issues
Yes,
tomorrow. So
that's
tune in
right. There are
tomorrow.
two people. Yeah.
Yeah, cool. So Jonathan is asking, could you please say more about the shift from evidence-based to evidence-informed and how this can be facilitated?
Yeah, evidence-based research really refers to the traditional way research is undertaken with randomised control trials and so on. Research in Australia is very heavily locked down by the National Health and Medical Research Council. And effectively what that does is it means that a person with an experience of suicide or mental health or whatever actually isn't heard in the research process. So evidence-based is based on very traditional narrow guidelines around how you collect information and how you test it and so on. That doesn't represent the real world. And actually there are academics now and researchers now who are working very hard to actually break through that. And the hearing voices area around psychosis and hearing voices, there's a lot of good research going on there, which is stretching the current traditional kind of parameters. So evidence informed is evidence that's collected that might not meet or does not operate the same way as the very narrow evidence gathering approach. Evidence-informed research is research which has more qualitative information, information based on what people are saying, and you analyse, that sort of information in a way that is different from the more statistical kind of very abstract approach. Now, I'm not saying it's either or. What I am saying is one of the problems we have in suicide intervention and also in mental health, but they're changing, is that actually you can't research things about humanity and life without actually having the flexibility to actually understand what the individual's perspective is. And gathering a range of individual perspectives is very different from a mechanistic randomized control approach. So both are important, and evidence-informed is becoming more accepted in some settings, but it's a long way behind in suicide prevention.
Thanks, Joe. Gary's asking, of all the things you mentioned and listed today, what would you say are the top three most important solutions Australia needs to implement to reduce suicide rates?
I think we need to introduce peer-to-peer support. That's the top, that would be number one for me. Groups like the Alternatives to Suicide group, where you have peers who are meeting and there aren't clinicians in the background. There is no risk assessment, there's no diagnosis, there's no intervention unless that's what the person wants. A place where people feel they can speak, they can share, they feel safe, they can trust. That's the number one, peer-to-peer support. I guess the second is growing lived experience leadership. And so people who are leaders in the suicide prevention area with the lived experience, many of those are family members and friends and very good people. Some of those are people with the lived experience of suicide attempts or thoughts. But by and large, there is no independent network. Like, they are all tied or linked with organisations. In the mental health sector, you actually have carer networks, consumer networks, where leaders are gathering independently of any organisation they might be employed by or other group that they are engaged with. That's missing in the suicide prevention area. And tied in with that, I guess the third issue is that agencies, including peak bodies like Suicide Prevention Australia, if they are genuine about engagement with lived experience, they have to walk the talk. It's not good enough to have a peak body in suicide prevention that says, you have a lived experience, we'll let you be an associate member and you can nominate for the board, but we're not going to give you a vote. You either accept or you don't. And I think Suicide Prevention Australia, if it was to change its position on that, would actually be modelling behaviour other agencies, its member agencies, should be taking up. Suicide Prevention Australia and agencies that receive suicide funding only exist because there are people who are in suicidal distress or people bereaved by it. That's the only reason they exist. And so what's going on when they actually cut them out of the conversation?
Thank you very much, Joe. Weng Sang is asking, in terms of accountability, how do we balance legal obligations if we don't do a risk assessment?
Well, look, the first thing I'd say, these are all great questions, you know, they're really important issues to flag. The first thing I would say about risk assessment is about 50% of the research around risk assessment unequivocally says it's only about half right. You know, it's not a great predictor. How risk assessments are used is probably the issue. If risk assessment is used in a way that is actually not the checklist, but it's something that the professional is working with, but engaged with the individual, listening to the distress, working with the distress. And maybe the risk assessment might be helpful under those circumstances. But what happens is people use risk assessments, they stop listening. They just simply stop listening to the distress. They can't, because they're looking for something in their checklist. In relation to the legal issues, there is actually emerging literature in the law that is really even questioning, well, certainly literature that is questioning the accountability or liability of agencies that support self-help groups. They're saying, well, self-help groups are self-help groups. People choose to go there. An agency that supports a self-help group isn't legally responsible for people who make choices about going to peer support groups, for example. The issue around risk assessment and negligence is a bit more complicated than we can chat about at the moment, but if people are acting in good faith and working in a way that is transparent and clear and connected, there are enough protections in the law if things go wrong. But in saying if things go wrong, if people feel that not using a risk assessment resulted in something that could have been avoided, well, you'd have to look carefully about what else could have been done. Risk assessments themselves aren't the answer, and that's pretty clear from the research. And even now you've got professional bodies openly questioning the use of risk assessments. It's about relationship and engagement and deep listening. That's where the work needs to happen.
Thank you, Joe. And for those who are interested on the topic, just look at the literature, have a look, and form your own opinions. And Joe, there are many, many more questions here. I wish we had the time to cover them all, but it's time to start wrapping up this session. So I'll give you the opportunity just to say some final insights, provide people with any recommendations if they want to find out more about peer-to-peer networks outside of the WA, if you know of any, or who to contact or which website to go to. So anything else you would like to share before we wrap up the session, it's all up to you now.
Okay, thank you. Look, I do realise I'm a professional myself, a social worker, and a life member of the Australian College of Social Work. I'm not being anti-professional in saying what I'm saying. I think professionals have a very fundamental role to play. But we don't have all the answers. And I guess what I'm saying is that professionals need to be a bit more vulnerable and accept that we don't have all the answers. And listening to people with the lived experience is part of the learning that we should be doing, because it's about mutual respect and mutual engagement. We have things to offer. People with the lived experience have things to offer. It's not either or. If you go to my website, Recovery Matters, there are some links with other organisations and groups like the Critical Psychiatry Network, Mad in America, Off the Wall, which is a Sydney-based group that runs alternatives to suicide groups, as well as the ones in Perth. There are places around that actually can help you reflect and think about where you're coming from and different ways of doing things. I'd really encourage you to get your local library to purchase the 2 books that are in the further information list, The Alternatives to Suicide and Broader View of Suicide, because that's research and information that is really about promoting life and not pathologising distress. It's the research that I think is going to help us into the future and certainly help reduce the rates of suicide in Australia. But at the end of the day, what I'm saying is, and what I'm hearing people with a lived experience say, is listen, deep listening, engagement, don't judge, allow trust to be built, create safety. Don't intervene if I don't want you to intervene, but certainly explore with me what's going on. The curious questioning is is what the alternatives to suicide people say is really what promotes hope and is life promoting. So thank you, Pedro and the Mental Health Academy for this opportunity. Much appreciated. And I wish everyone well across the weekend. Thank you, those who have listened. And we hope to see some good changes happening in the next few years under the careful leadership of Christine Morgan and others.